Hello, good morning, everybody. It is my pleasure to, does this work? Yeah, good morning. Thank you for having me here today. It's my pleasure to be here among my colleague internists, physicians, and health allele in the 10th Emiri Diabetes Conference. As Dr. Awsam presented me earlier, I'm a bariatric surgeon and intensivist in Emiri Hospital, and I work sometime in critical care ICU in Jabir Hospital as well. So today I'll be talking to you about surgical management of diabetes and obesity. I have no disclosures. So why do we need to talk about obesity and diabetes? Diabetes and obesity is really causing a huge epidemic problem worldwide. There's a huge health impact, and there's actually years of life lost for those who suffer from these diseases. And there's a lot of economic burden that these patients who are suffering from it cost their countries and the whole wide world. So we're just going to talk a little bit about each one of these points. And what's important is that even with all the management that is out there for obesity and diabetes, we're still far behind when it comes to management and prevention. So there's about 1.9 billion people who are suffering from overweight and obesity. And from this 1.9 million, there's 650 million people who live with obesity every day. And these are adult patients, not including adolescent and children. And those who have diabetes, there's over 537 million. So it's quite a huge number of people in the world suffering from these two diseases. If you want to look at the numbers in Kuwait also have a very high prevalence of obesity, with about 7 for adult people, it's about 7 out of 10 people suffering from either overweight or obesity. So women have about 44% prevalence of obesity, and men have 36.6%. And you can see that the pattern is slightly different when we talk about children, but our focus today in my talk will be basically around adults. So it's quite astonishing number to see such a disease that we actually suffer from in our country, and we still do not have a strong national program that cater for these patients. If you look at prevalence of diabetes in Kuwait, it's about 25.5%. So it's a little bit less than obesity, but it's a still huge and high number. There's about 800,000 people of people in Kuwait who are suffering from diabetes. So with that, we're going to talk a little bit about the impact of obesity. As you all know, there's a lot of condition that has been associated with obesity, including cancer, of course, obviously diabetes, and all the metabolic syndromes. And the truth of the matter is that these diseases are not isolated. There's a lot of genetic predisposition, a lot of genetic linking when it comes to these diseases that patients with obesity suffer from. So as you can see, obesity overlaps with diabetes, dyslipidemia, and hypertension, and there's more and more that comes out from in the literature that talks about this as well. And we want to come and talk about the loss of life. This is an old study that was published in JAMA in like 2003 that looked at the years lost for the people who have obesity compared to those who the expected for how long that they would live. So they found that in white men, if they have severe obesity and they between the age of 20 and 30, they lose about 13 years of their life. A bit less to the white woman, and up to 20 years for black men, and 5 years for black women. So just to put this in consideration, such a disease, it really needs to take a lot of attention. And if you look at metabolic and bariatric surgery, there are studies that compare patients who underwent metabolic and bariatric surgery compared to those who did not. And there's actually a reduction in mortality for those who undergo the bariatric surgery. So there's like about 89% for 5 years risk of the death reduction. And for those who have diabetes, you can see there's the highest as well reduction of death if they undergo metabolic and bariatric surgery compared to those who does not. This will bring me to the last point when it comes to the earlier points that I was talking to tell you about why this disease is important to tackle, is that the economic burden. There's a lot of money that is being spent. These stats are from like different countries that you can see here, with a lot of money spent on treating obesity. And if we want to look at Kuwait, Kuwait is not far behind. We spend about close to $2 billion in the treatment of obesity, and it is speculated that this cost will keep increasing as we move forward. So we do have, this complex disease that have a lot of elements in that we are still struggling to treat. We have different options to treat our patient with that. So some of the options we have is metabolic and bariatric surgery. And as a surgeon here today, I'll be speaking to you a bit more in depth about what metabolic and bariatric surgery offers for the patient. So to start with, let's talk about what is metabolic and bariatric surgery. So metabolic and bariatric surgeries are surgery that are performed in the GI tract in the goal of treating the comorbidities that is associated with the obesity. So and I know that we always talk about, we always say like bariatric surgery, but if we want to be more accurate in terminology, if the goal of the treatment was to cure the underlying comorbidities that the patient have, it would be better to use the metabolic surgery compared to if the procedure is driven only solely based on the weight. All right, so a little bit about the physiology, and I'm sure here all of you know about that. So how does metabolic surgery work? So there is a lot of pathways that this surgery alters and change in our body as it's performed in the GI tract, but also the extent the changes occur in different tissue, as you all know. So there's there's increase in insulin secretion, increase in the sensitivity. There's a lot of microbiota that can change, and so forth. And then with that change, some of the side effects that we see is actually the weight loss, but there's a lot of physiology that is happening in the body. And I know maybe as internists or people who prefer, like non-surgeon, I would say, audience, sometimes bariatric surgery gives you a little bit of a reluctance. So it's like you care about your patient, you're not sure about the risk, you're not sure about how safe the surgery is. I want to assure you that these procedures have been going on for over 73 years. So there's a lot of procedures that have been going on since the 1950s with some of these surgeries have been abandoned because of their high morbidity and their high risk of complications, but there are more procedures that are being also innovated and evolved. And then my colleague will be talking today to you for the endoscopic portion of the treatment of obesity, which I will not be including in my talk. But what took actually metabolic, so if you ask yourself, well, it's been going on since the 50s or the 60s or the 80s, how come now it is more adopted? So when laparoscopy came in the late 80s and early 1990s, the adaptation of the bariatric surgeons for the laparoscopic approach have actually changed the game because the length of hospital is shorter, the patient's recovery time is faster. And therefore, you can see now that there's increased adaptation for the metabolic and bariatric surgery because of that technology. So let's talk a little bit here about the metabolic and bariatric surgery, and this is here what I want to share with you, hopefully to clarify for you maybe some of the questions that may be not clear for most of the internists. So metabolic and bariatric surgery, you can think about it as a primary procedure or a secondary procedure. So for the primary procedure, for example, these are procedures where patient never had a surgery into their GI tract in the goal of treating obesity or weight. So you have sleeve gastrectomy, you have Roux-en-Y gastric bypass, you have adjustable gastric byband, you have biliopancreatic diversion with duodenal switch, you have single anastomosis duodenal ileostomy, and you have one anastomosis gastric bypass. And I know maybe these names are confusing, and yes, there is some of the blame to share with the surgeons because if there's like one anastomosis with the stomach, they will tell you one anastomosis or mini gastric bypass. So I understand there's a confusion, but what you need to understand is that these surgeries all have differences in terms of how they work with each patient, and their results also are a little bit different. And of course, not every procedure is for everybody. So you have to be selective for each of the procedures. So I have here some of the pictures that I can show you here. So for example, the first one here, which one is the pointer? Is there a laser here? What are the mouse? How can I, is there a pointer? Which one? This one? Here. Okay, good. So here you can see the sleeve gastrectomy. So you can see here just the stomach has been resected. Here you can see the raw and wide gastric bypass. So there's two anastomoses. There's one here at the gastroduodenal anastomosis, and there's another anastomosis here. This is the gastric band, which almost being abandoned at this point, as a lot of patients requiring further surgery after that surgery, either for removal or another bariatric procedure. And then you have, for example, you have here the duodenal, biliopancreatic duodenal switch. And also, there are some differences in terms of techniques of how to perform each of these procedures. Now, here is the one anastomosic gastric bypass. And so there's actually one anastomosis with the bowel here, but also you can see that the fashion is different. And these are two different techniques in terms of how to do that surgery. And then this is a SADI procedure, if you heard about it. So the anastomosis is between the ileum and, so not the jejunum, the ileum and the stomach. So as I said, some of these procedures have been adopted and endorsed as first procedures in the primary. And sometimes what we need to do is that the patient require additional surgery. And then this is when we call secondary surgery. So all that procedures that I showed you earlier can be performed as the first step for the treatment of obesity for a specific patient, but also some of them can be done if the patient had, for example, weight regain. What you need to know that secondary surgeries can be done for different indications. So you have, for example, if a patient have, for example, a sleeve and had a leak, or had a raw and wide gastric bypass and had a leak or a perforation, et cetera. So there's acute complications that require a second surgery. There's surgeries that are done because of chronic or long-term complications. For example, a patient needs a reversal of a procedures because they had a malnutrition and so forth. And then sometimes there are side effects, but not long-term complications. So you need to restore. So patients sometimes have a different pathology that came in, and you need to restore the anatomy. And then also there is, for weight regain surgeries, again, there are some surgeries that you could do to enhance surgical procedures. For example, for raw and wide gastric bypass, you can do distalization and so forth. So there are different indications for revisional surgeries. Now, what you need to know is that unlike primary surgeries, the secondary surgeries, whether for whatever indication it is, usually it's a little bit more complex because the tissues are not the same. Again, sometimes the patient's condition is different, so there's increased hospital stay, and there's a higher rate of complications after the revisional surgery. However, it is effective for many patients, and therefore we go ahead and do it. What I want to share with you here is and I don't know if some of you have a look at this one, the International Federation for Obesity Surgery, the EFSO. They do have in 2019, and they do have afterward as well, their registry where they put all the cases of metabolic and bariatric surgery worldwide. But you need to understand that these are not all the absolute numbers, because not all countries participate, and in some countries it's only single institutions that participate. So just to give you an idea, sorry. I'll go back. All right, I guess you saw all my next slides. Here we go. So, sorry. So you can. So these are the numbers that were included in the 2019 registry. Over 833,000 procedures from 61 countries. And if you want to look at the MENA region, where Kuwait have a national registry, so Kuwait is included in this data. You can see that the most performed procedure is a sleeve gastrectomy. You can see here this is the sleeve gastrectomy in the orange, and if you look here, it's a Middle East region, same thing. But if you look at the single anastomosis, you can see it's performed way much less, and even raw and wide gastric bypass to a less extent compared to, for example, the United States and other countries. About more than 99% of these procedures, as I said, done laparoscopically, and worldwide sleeve is the most performed procedure. These are procedures in different countries in the MENA region, and in Kuwait, sleeve gastrectomy is the number one procedure with, when I look at percentages per procedures, Kuwait has the highest percentages according to the population, with female being the most, more than 75% of patients undergoes that, and the rest are low. Now, with all that being said, and I want you to remember the slides where I talked to you about the number of million of people who suffers from obesity and diabetes, there's only 1% of patients who are eligible to have surgery actually undergo surgery in the United States for metabolic and bariatric surgery per year. So it's going to take forever to be able actually to provide care for these patients. So now let's talk about a little bit about the benefits of metabolic and bariatric surgery. So there's a lot of benefits, and I have spoke to you earlier about reduction in mortality, but also many studies shows that there is a long-term weight loss outcome that is better than non-surgical management, and of course decrease of, we spoke about the mortality. Surgery is very safe, and perioperative mortality is actually very low. Plus, there are more studies coming out that shows that there is actually a reduction for cancer risk after metabolic and bariatric surgery. This is a study from the Middle East that looked at safety within the Middle East, and the rates of complications in terms of leak and so forth are pretty much comparable to the international numbers, with about 1.9% risk of leaks. If we want to talk about specifically diabetes remission, so there are so many studies that looks at that long-term in terms of over 5 years or 10 years, and across all studies, there has been the percentage of diabetes remission can be early in some procedures, as, for example, 75%, maybe later on by the 10th year drop to the 50 or the 30 range. In terms of weight loss, of course, bariatric surgery is more durable. These are studies that shows weight loss over 20 years. And as you can see here, that the surgical arms, regardless of what surgery has been done, have shown more sustained weight loss compared to patients who did not have surgery and underwent only conservative management. Of course, there are other impacts on other comorbidities, but we're not going to talk in details about these. But we do know that there's also significant remission in other comorbidities with metabolic and bariatric surgery. And if you ask me which of these procedures are better, I'm going to tell you it all depends on what your patient have, right? So as you can see, this is from the Canadian Guidelines 2020, where they had reviewed studies that looks at different kind of procedures and what percentages of improvement of comorbidity. So for example, if you talk about diabetes, you can see with the highest would be with biliopancreatic duodenal switch with up to 80%, but also there are some data that could show up to 96% resolution. And if you look, for example, to Roux-en-Y gastric bypass, it's a little bit less and a little bit less of sleeve gastrectomy, but definitely there are patients who go into complete remission. And then there are obviously other comorbidities, as I said earlier, that will vary differently between different procedures. What you need to know is that each of these procedures long-term may have some different side effects or different complications. So as you follow your patients, it's important to be aware of these ones. Now, this is a new study that is hot out of press, as they say, that's published in the Obesity Surgery, and it looked at diabetes remission long-term in patients with a very, very high BMI. So BMI is more than 50. And they compared head-to-head sleeve to Roux-en-Y gastric bypass, and in their conclusion, over 5 years, they did not find a difference, so sleeve is as good as Roux-en-Y gastric bypass, because there's always the notion that Roux-en-Y gastric bypass is superior to sleeve and so forth. So in terms of the choices, because you do have sometimes patients who would refuse, and this is, I find here, a lot of patients, they're not open to have Roux-en-Y gastric bypass or duodenal switch, and they want to have sleeve gastrectomy. So it's important to take the patient preference in consideration. So if you want to look at indications for metabolic and bariatric surgery, you have the American Society of Metabolic and Bariatric Surgery, 2022, and the EFSO indications that was published in October 2022. It's actually a very good good guidelines because it does review the previous NIH guidelines that was published very early in 1991, and there was so much fixation with the BMI and eligibility for surgery, which we know that now is not the case. So one of the major updates from these guidelines is that metabolic and bariatric surgery is recommended for patient BMI more than 35, regardless if they had comorbidities or not. And you would consider the metabolic and bariatric surgery if even the BMI is between above 30. Another point that they have mentioned, which is catering for the ethnicity and the background, which we know is very important when it comes to the pathophysiology of the disease in certain patient populations, such as the Asian, for example. So they did lower the threshold to put it for a BMI more than 25, that it is suggestive of clinical obesity in the Asian population, and you could offer metabolic surgery for these patients. The guidelines is actually pretty good because it also looked at other aspects that was not addressed before, which is utilizing metabolic and bariatric surgery for other patients groups, such as patients who require hip replacement, abdominal wall repair, or a transplantation. Because we have a lot of patients who need to have these surgeries, but their obesity can prevent them from these, so you could use these procedures to bridge them. I'm going to stop here and just ask you a question. So I'm going to tell you about this patient who she was diagnosed with breast cancer about maybe 7 years ago. And when she was diagnosed with that, she underwent lipectomy. She had a local disease, so she underwent lipectomy, had radiation, and had hormonal therapy, received some chemotherapy, and she was treated. She was happy that she was cured a few years ago. And then one day she presented to the clinic, and she was complaining that she's concerned that she could have a recurrence at the site. Investigations have shown that the patient may have a recurrence in the breast, and then possibly distal metastasis. The patient would be referred to medical oncologist. If you were the medical oncologist or you were the doctor who would be referring this patient, would you suggest that this patient should get a treatment for her recurrent disease? Can I see show of hand of who would send this patient for treatment? No one? So she had a recurrent breast cancer about 7-10 years after the initial diagnosis. Who would send this patient for treatment? 1, 2, 3, 4. That's it? You're gonna let this patient die? I want to see more. I've seen maybe 10. No? Dr. Amsan, Dr. Hawra, would you send this patient for treatment? Okay, so I would send this patient for treatment. I do, even if I'm not the specialist in oncology, I do want her to see somebody to assess her properly and decide what line of treatment that she will need, right? So we have some people who said yes, they would treat. But if I show you this patient, and I tell you this patient had a sleeve gastrectomy or had a band that was inserted before, would you refer her again because she had a weight gain? So the purpose of me showing you these two photos is that we do have a lot of bias sometimes, unconscious bias in treatment of disease recurrence for patients with obesity. And this is what I wanted to highlight with this photo. So weight regain is a problem, and it is because in a lot of, I would say in many patients, the driving is actually the underlying disease rather than the patient themselves not being compliant for their therapy or their treatment. So there's a lot of compensatory mechanisms that could happen biologically, so whether the patient undergo diet to lose their weight or they have surgery. Of course, surgery is more superior, but still these patients, a group of patients, will have severe disease and they will have a recurrence of their obesity. So it's important to take this in consideration. And as we know, obesity is a chronic disease, it's progressive, and it's relapsing. So we have to keep an open mind when our patient comes in and they do have that problem. I'm showing you this figure just to show you that different procedures work differently. They all result into a weight loss, but they do on the hormonal and the biochemical level, they work slightly differently. And we know that genetically patients are also different because we do know that there are some patients who are resistant to gain weight, and there are other patients who would actually, according to their environment and their genes predisposition, they are more prone to get obesity. So it's important to take these factors as we treat these patients. So weight regain is a real problem. More than between 20 to 35% after they undergo bariatric surgery, they could have the disease come back. So it's important that you would have a strategy for their patient when they come back. Utilization of pharmacotherapy, as we know now, there's a lot of there in the market. There are a lot of studies that looks at different medication. So this is just an example of using liraglutide after a Roux-en-Y gastric bypass and looking at the weight reduction. And there is a good weight reduction after utilization of pharmacotherapy. I always advise my patient, if they ever start to regain weight, is it to present early so you can intervene with the disease. And of course, you need to re-educate these patients and do everything, but you cannot deny them the fact that they need treatment. So in terms of selection, we sort of touched upon that, but what I want to highlight in these slides are the role of multidisciplinary care teams in the care of obesity. Guidelines do recommend that you would do MDTs for your patient, but it's important also not to delay their surgery, and the surgeons has to be the one who decide if the patient is ready to go to surgery. This is a study that was done in the UK for about 200 patients. They had 1-day MDT, and then they looked at the decision-making and how the process in the MTD, if that process will change actually the outcome or not. And what they found is that in about 45%, there has been disagreement during MTD, and that actually instigated about 78% in the plan change. Now, eventually, all of the patients, the 200 patients, 80%, 85% underwent surgery, but there was a change in the plan prior to that surgery. So what I want you to know is MDT is extremely important to have, it can actually change maybe the workup or something else for your patient, but it should not prevent their surgery. Now, in Amiri Hospital, since this is a Amiri conference, in Amiri Hospital, we do have that. We do have the ABCD clinic in Amiri Hospital that was founded in end of 2019. And in this clinic, we provide our patient with different services. We have a specialized team from surgeons to obesity medicine to psychiatrists, pediatrics, adolescents, different specialties that come and discuss patient care. We have our system that is geared to serve these patients. We have dedicated HER for that clinic, and we have full IT support. So it's important that we do what we preach. Now, there is a specific pathways that the patient will go through. I don't want to take time from this talk today to talk about it, but if you are interested to learn more about the clinic and the services we have, please feel free to reach out for me or my colleagues here, Dr. Aisha and Dr. Asrar, who are integral part of our team. We have so many patients that we served, and we do monitor our patient, and we have a dashboard where we look at our KPIs, and this is an ongoing process because it's important not only to start a service, but also improve it and take it to the next level. So if we want to go back and talk about how do we define success for those patients who we selected and we did metabolic and bariatric surgery for, it's important to look at all the possibilities and the outcomes, such as the complication, the weight loss, and so forth, and the things that I spoke to you earlier. But what's important as well is to take the patient outcome and their reported outcome. So how do they feel? What are the things they've been going through after surgery? And these are the areas that we really need to do a lot of work here. So every patient will have different goals, and therefore their success will look different. And this will bring me to the end of my talk. And I'm just going to highlight with you the few things that we talked about, which is how diabetes and obesity are prevalent worldwide as well as in Kuwait. There are a lot of ways to treat these diseases. metabolic and bariatric surgery is one of the important tools that is durable and have good outcome, but is not fully used to its full extent. We touched a little bit about the guidelines and the indications for the patients, so I encourage you to actually go and read it and take a look at it and see how it applies to your patient. And we did mention about MDT and how this is important into possibly change the plan for the patient if they're undergoing surgery. And with all that, it is also important to highlight that at the national level, I think we need to do a lot of more work when it comes for obesity and diabetes.